Bhopal, Priya Dhamelia from Surat, Sadashivdu Gundeti from Hyderabad, Dr. Sekat Datta from Bhopal, Sailesh Lavana from Vadodara, Urmi Mala Bhattacharjee from London, Yu Mon Thant from Myanmar. And now it's time to introduce Professor Yen Appelli to you. Well, she has been to India in one of our MHG meeting in past as our faculty, and today she is doing a webinar for us. She is chair of the Department of Hematology at the Imperial College and the chief of the service for clinical hematology at the Imperial College Healthcare NHS Trust in London. She served as the president of both the European Group of Blood and Marrow Transplantation and the British Society of Blood and Marrow Transplantation. She also serves as the advisory board of the Center for International Blood and Marrow Transplant Research. She qualified in medicine from the University of Birmingham, and after her initial specialization in internal medicine, she completed specialist training in hematology in Birmingham, London, Cambridge, and Boston. Her interests are the biology and management of CML, which has led to an extensive experience in stem cell transplantation and to the use of signal transduction inhibitors. Her group at the Hammersmith Hospital site have extensive experience in the use of various generations of TKIs, particularly in the areas of molecular monitoring and mechanisms of drug resistance. She has a long-standing interest in the ways in which hematological diseases and their treatment impact fertility, pregnancy, and fetal outcome. She will be speaking to us today on Asciminib-based treatment of CML. Before that, our special guest, Dr. Deepak Charles Kochi, is our chief guest for the day to inaugurate our webinar and also give us some words of wisdom. You all know him. He's consultant hemato-oncologist and stem cell transplanter from Esther MedCity, Kochi. Deepak, over to you to inaugurate this webinar.
Thank you, sir. Thank you for this opportunity. First of all, I would like to thank Dr. Agarwal sir and the team of Mumbai Hematology Group for having me as a chief guest for this program. We are always in awe in the way this MHG group led by Dr. Agarwal conducts this program. He in fact has thrown open the field of hematology without barriers to everyone in India. Why I had a lead like this is because there was a time during my undergraduate days or graduate days where the field of hematology was not this well known. And I was invited into the field of hematology during my graduate days, where under the guidance of Dr. Shashidharan from Calicut, where I had the opportunity to work under him. He had a department of hematology by itself where he used to give chemo. So I had this exposure much early. So the field of hematology at that time was not well known. And in fact, before I went for my DM training, I was asked in an interview, one of the premier institutes, why do you want to take up hematology? So I told them down south, whenever you ask what is hematology, I get the answer back as dermatology. You are specializing in dermatology. So hematology was not known at all. So I wanted to tell them that yes, hematology is a branch which caters to a wide range of population, and it is its own advantages there. After completing my DM, I got back and I'm currently working in this present center for the last 8 years. What I understood was that there is a lot of advances happening in the field of hematology, both in the diagnostic and the therapeutic aspects. But most of them have been in molecular and targeted treatments. Yes, they are, of course, needed in the field of hematology. But I don't think that there is more thrill than diagnosing bedside a thrombotic microangiopathy or APML by looking at SMEs. So as we embrace the advances in the field, it's important for us to get rooted to where we came from and never forget the basics and be always with the patient-centric in our approach to any further care in hematology. So whoever students are there with us in this program, it's important that we balance both the advances and the deep-rooted scientific principles which we came up from and take it further in the field of hematology. Once again, I thank Dr. Agarwal for his invite and hope that we can balance our family also during these training days and the advances in the field of hematology. Thank you.
Thank you, Deepak, for those words of wisdom and your experience. Grateful to you for sparing your time. And now over to Dr. Jen Appelli for her lecture.
Hello, everybody.
Hello.
And thank you very much for inviting me. Um, just before everybody joined, we were joking because it's very early in the morning for me. But fortunately, the England-India cricket match, the test match, is on. So I had some entertainment before I was able to join you. It gives me a great pleasure to join you today to talk about Asciminib, which is the latest drug in the armamentarium for chronic myeloid leukemia and holds some very considerable promise. These are my disclosures, which I don't think will come as any surprise to anybody who works with TKIs. And I often start my presentations with this slide, so I apologize if you have seen it before, but I think it remains quite a good instructive slide, not only of the history of CML in this century, but also particularly struck by the words of our guest, also makes you stop and think a little bit about what you're trying to achieve with each and every patient. So basically, when the TKIs, when imatinib was introduced back in 2000, those of us who had been working with CML at that time, we really just wanted to prolong survival because the median survival of CML, even with interferon, at that time was still only about 5 or 6 years. Now, nobody dies of CML unless their disease progresses to blast crisis, unless, of course, they die of transplant-related mortality with transplant. So the goal early on was just to delay disease progression because that should lead to prolongation in survival. And then, of course, the TKIs, imatinib, was really...
Ma'am, your voice is getting muffled.
Sorry?
Yeah, your voice is getting muffled intermittently.
Oh, I'm sorry about that.
Closer to your mic. Yes. Now it is very distinct.
Really?
Yes.
I don't think I'm doing anything different.
I think with the movement of your neck, when you go to little on the left and the right, then the voice gets muffled.
So if I'm straight on, it's okay.
Perfect. Yes.
Okay. So when we realized that imatinib could achieve cytogenetic remissions, that became the goal. And if you think back to the guidelines that were written between 2006 and 2009, it was all about trying to achieve cytogenetic remission. But of course, that wasn't enough for anybody interested in CML once you realized that you could achieve molecular remissions. And I suppose the last 10 years or so have really been about driving to get molecular remissions. First of all, because these allow a number of patients to consider treatment discontinuation and possibly have a prolonged treatment-free remission. And it meant that we started using the second generation drugs in front line because we wanted people to get their deep molecular responses as early as possible so that we could get them off the drugs as early as possible. And that's led to a little bit of a backlash, I think, because some of the second, particularly one of the third generation drugs, have a lot of side effects. And so whether it was correct to keep driving for these deep remissions is now in question. And as we are preparing the latest version of the ELN guidelines, this topic about whether you should be driving for deep remissions in every patient is particularly topical. Having said that, there is absolutely no doubt that a proportion of patients will do really well and will be able to come off the drug. So I guess the art for us in the next few years is to try and individualize treatment to get the best outcome for every patient. You'll be very familiar with this slide, I think, so I won't dwell on it, but it just indicates from this beautiful piece of work from our colleagues in Scandinavia that the life expectancy of the vast majority of patients diagnosed with CML today is actually the same as the normal healthy population. What they've done in Scandinavia is look at men aged 55, 65, 75, etc., and look from the 1970s up until about 2015, what loss of life expectancy a diagnosis of CML would make. And you can see that that loss gradually diminishes over the years with an enormous improvement between 2000 and 2015. But I guess the purpose of today's talk is really to focus on the patients who aren't doing very well. And I've also used this slide a lot. I borrowed it from Tim Hughes, who gave it at an ASH education meeting. And it just is a schematic of what might happen to patients diagnosed with CML. So blue diamonds are the patients who do exceptionally well, get deep molecular responses early on, and then they may be offered the opportunity to stop. The pink diamonds are the people who do absolutely fine, but their best response is probably major molecular remission, and they will remain on drug lifelong. But the focus for today are the red diamonds and the gray diamonds, because the red diamonds are patients who just don't respond to their first-line drug, and the gray diamonds are those who respond and then lose their response. And this accounts for around about 20% of our patients still, even in 2024. And they are the patients who are still at risk of dying of CML. So what we would like is a treatment that manages to rescue at least a proportion of these individuals. So I'm going to illustrate my talk with some case histories. So the first case is a 39-year-old man, and he presented, as you can see, some years ago now, 2006, very typical presentation, weight loss, night sweats, a blood count that's very characteristic of CML. He was Philadelphia positive. He had no additional chromosomal abnormalities. And in retrospect, he was an ELTS intermediate score. We started him on imatinib because that was the only drug we had first line in 2006. But his best response was only complete hematological remission. We looked for a kinase domain mutation, wasn't there. We did the only thing we could do in 2006, which was to increase the imatinib to 600 and then 800. In 2008, nilotinib became available in the UK on an expanded access scheme, and we gave him this. And as you can see, at 12 months, we thought perhaps he was beginning to make a good response, but by 18 months, he had lost that response with a PCR of 54%, and the kinase domain mutation test detected a F359B. And if you look at the traffic light diagram on the side, you will see that the F359B is not particularly responsive to imatinib, should be okay with nilotinib, but probably does best with dasatinib or bosutinib. So bosutinib became available in 2009 through one of the Pfizer studies. And he started this, unfortunately, at the very high dose of 500 milligrams daily. I'll come back to this later when I'm talking about the Assemble study. But unsurprisingly, he developed immediate diarrhea, was not very keen on the drug at all, but persevered. And at 3, 6, and 12 months, he started to have a response in his RQ-PCR, not the best response, but better than he'd had before. He was very keen to try and improve that response, so he volunteered himself to increase the bosutinib dose, putting up with the gastrointestinal disturbances. And the RQ-PCR at 18 months, gratifyingly, showed a major molecular response. And he stayed on this big dose of bosutinib for a long time. But in 2018, he lost his major molecular response and a V299A mutation was detected. So I think the 299L is on this, traffic light diagram, but the F299A is known to respond to dasatinib. So he was changed to dasatinib in 2018 and got a very good response. You can see he was in an MR4 12 months after starting dasatinib, and perhaps in retrospect, that's a drug we should have used for him back in 2008 or 9. Unfortunately, some years after starting dasatinib, he came back into clinic talking about shortness of breath, and a chest X-ray showed bilateral pleural effusions. The dasatinib was discontinued. The pleural effusion didn't clear in the first couple of weeks, so we added some steroid, and he had an echocardiogram that suggested he might have an element of pulmonary arterial hypertension. So we're really in quite big trouble with this guy. You can see on this schematic his RQ-PCR, which was certainly responding to dasatinib, but once we had to stop it for the pleural effusion, it began to rise again. We tried the dasatinib again at a much lower dose. That's the smaller blue bar at the top. Again, his disease was responsive, but by this time we'd got the echocardiogram result and were a bit worried about continuing dasatinib in the face of pulmonary hypertension. So what are our choices at this time? We needed another drug for him that didn't have the same side effects, and the drug that we were most familiar with, of course, was ponatinib. And these are the results of the PACE study, which was ponatinib for the failure of 2 or more TKIs, and also for patients who had a T315I mutation. And ponatinib is an amazingly powerful drug. So if you look at this very poor risk group of patients, then ponatinib will induce a complete cytogenetic remission in over 50% of them, and indeed a major molecular remission in some 40%. And you can see from the color of the bars that actually it's much more effective in doing this in patients with the T315I mutation. So that's the perfect place for ponatinib. There were, however, many patients in this study who had been intolerant to previous drugs. So this is the reason that we would consider ponatinib for this particular patient. But we also know that the worrying thing out of the PACE study was that at 4 years, there was approximately 30% incidence of arterial occlusive events, so cardiovascular, cerebrovascular, and peripheral arterial occlusive disease. So by this time, our patient is quite a lot older. He's already had pulmonary effusion, a pleural effusion, and pulmonary hypertension. So ponatinib may not be the drug of choice in this case. Now, I'm not going to dwell on this, but I think you'll also all be familiar with the fact that we know ponatinib is an excellent drug, but we were worried about the side effects and the fact that this was dissuading both physicians and patients from using the drug. So Takeda and Insight did this very nice study known as OPTIC, where they randomized patients onto 1-to-1-to-1 basis of 45, 30, or 15 milligrams of ponatinib daily. Patients had to have failed at least 2 prior TKIs or have a T315I mutation, and the end point was achievement essentially of complete cytogenetic response, a PCR less than 1% at 12 months. Now, the interesting thing about this study is that once the patient had achieved that endpoint, if they had were on the 45 or 30 milligram arm, they dose reduced immediately to 15 milligrams to see if one could reduce the possible adverse events of ponatinib at the original dose. Now, the OPTIC study has been very successful. It has encouraged people, I think, to use ponatinib in the right situation, and certainly the right situation for me is a T315I mutation or demonstration of multiple resistance to prior TKIs. Whether it's the right drug for patients who are intolerant rather than resistant is another matter. Unfortunately, we now have Asciminib, and I'm hoping this little video is going to play for you. So this is the normal ABL1 protein, and the bright blue is the myristal sequence, which binds to a myristal pocket and locks the molecule into a closed conformation. When that terminal is replaced by BCR, BCR can't lock into that myristal pocket, and the molecule remains completely open. But if we use Asciminib, which blocks the myristal pocket, it closes the molecule into the inactive conformation. And I don't speak as fast as the picture, so I hope you got the general message. We'll move on from that. So if you look at the activity of Asciminib on the left in green against the various mutations that we commonly see in CML, and compare that to nilotinib in purple, you can see that Asciminib is highly effective in lots of mutations, but on the left are a series of mutations that one might anticipate would cause resistance to Asciminib as they're based around the myristal site pocket. And on the right, you can see the ones that have been appearing clinically, the A337B, P465S, and V468F. So although Asciminib is a very nice drug, has activity against all the usual mutations, although there is some debate about T315I, we will begin to see mutations that are around the myristal site. And this is important in your molecular lab because they have to extend the range of sequences that they look for when they're looking for mutations. Now, there was an update of the phase 1 study of Asciminib at ASH, and I have some of those slides that I thought I would share with you. Now, when Asciminib was introduced into clinical practice, you can see from this very busy slide that actually there were a number of studies which started almost simultaneously. So the top one, which is the first study, was Asciminib in CML that was resistant or intolerant to at least 2 TKIs. And first of all, there was a dose escalation part of this for safety, and then a dose expansion at the chosen dose of 40 milligrams BD. There were clearly other studies. There was a study of Asciminib in T315I at much higher doses, chosen dose eventually 200 milligrams, and Asciminib in Philadelphia positive ALL, and then Asciminib in combination with imatinib, nilotinib, and dasatinib. The next couple of slides are just about the top study, study 1. So there were a lot of patients who got Asciminib in the dose escalation, but only 30 who received it at 40 milligrams BD. And then there was an extension to see whether a single daily dose would be as effective. So 17 patients got 80 milligrams daily. And this is important because BD dosing, as Novartis had learned from nilotinib, tends to encourage a little bit of non-compliance. So there's a lot of detail on this slide. You can read it at your leisure if you like, but basically, if you look at the bottom line, over 50% of patients were still on Asciminib at the end of the trial analysis, which is actually a very good result for a drug that is coming at least third, if not fourth, fifth, or sixth line. And if we look at the achievement or maintenance of major molecular response on Asciminib monotherapy, and this is Asciminib 40 BD 80 once a day for all patients in the green, you can see that it has a very good chance of achieving a major molecular remission in many of our patients. So that was the indication that it was a highly effective drug, and probably, if you think back to the results of the PACE study, probably equivalent to ponatinib. There is still a question around Asciminib about arterial occlusive events, because there were a number of arterial occlusive events reported in this study. Relatively few at grade 3 or more. And obviously, the drug is being used not only in patients who may already have pre-existing ischemic heart disease or hypertension or diabetes, but who had also been exposed probably at least to nilotinib and many also to ponatinib. So it's at the moment, it's a little bit hard to interpret this. I would say that it's a pretty safe drug, but the jury is still out as to whether it's completely safe from the cardiovascular perspective. This is an interesting slide because it breaks down in the 3 lines to patients who had had asciminib after 2, 3, or more than 4 prior TKIs. And if you look at the 0 months on treatment, to the left is the amount of time that they had managed to spend on their immediately previous drug, and on the right, the amount of time that they were able to stay on asciminib. So I think this slide is basically telling us that asciminib is a very well-tolerated drug, and presumably patients wouldn't stay on it if they weren't responding. So it's a very encouraging picture from this phase 1 study. So this is exactly what we did with our first patient, who you remember PCR was going up once we'd stopped the dasatinib, and we weren't very keen on continuing dasatinib. We started him on asciminib. He had an immediate PCR response, and it has been incredibly well tolerated, and he's back enjoying life on the golf course. Now, we got asciminib in the context of a study at that time, but we were also very much engaged in the ASSEMBLE study. Now, the ASSEMBLE study has been published, and it's been presented at many, many meetings. I've got a few slides of the ASSEMBLE study because, particularly for the younger members of the audience, they may not be so familiar with it. But also, it's important because this is a study that got asciminib its license for patients who had failed at least 2 prior TKIs through resistance or intolerance. Now, this study was a randomization between asciminib and bosutinib in patients who had failed at least 2 prior TKIs. It's not the same as the PACE study for ponatinib. I mean, first of all, the PACE study was a single-arm study. But no patient could enter this study if they had a T315I mutation, because bosutinib is inactive against the T315I, and it's also inactive against the V299L. So that meant that those patients had to be excluded. The randomization was a 2-to-1, so twice as many patients got asciminib as bosutinib. And the ask of this study was really quite tough, because it was major molecular remission at 6 months in a group of patients who had failed at least 2 prior TKIs. So that was asking a lot of this drug. And gratifyingly, at week 24, you can see that some 25% of patients on asciminib had achieved MMR. I should say that you weren't allowed to be in MMR to enter this study, so this is a real achievement. And this was about twice as high as the proportion of patients who managed to do this on bosutinib. By week 48, there was a slight improvement in the numbers of patients who had achieved MMR in the asciminib arm, but not in the bosutinib arm. And you can see at the latest time point, again, almost 40% of patients had achieved MMR on asciminib, as had achieved it on with a much smaller level on bosutinib. I don't know if you remember, but the proportion of patients who achieved MMR on ponatinib was also 39%. So it looks like very similar efficacy between asciminib and ponatinib. And then if you look at MR4 and MR4.5 rates, you can see that they're higher with asciminib than with bosutinib, which is what you'd expect. But they're still relatively low for Asciminib, because even if it's a very good drug, you're talking about a very poor risk group of patients. But almost 20% at 2 years, which is very encouraging. This slide looks the same, but in fact it's not the same because it's not MMR, but essentially complete cytogenetic remission. So a BCR-ABL less than 1%. And you can see, again, the difference between Asciminib and Bosutinib is maintained with twice as many patients achieving a good response with Asciminib than with Bosutinib. And one interesting thing from this study, because sometimes when you do a randomized phase 3 study, the control arm doesn't always behave as it did originally and historically. But if we look back to the use of Bosutinib in third-line patients who had failed at least one second-generation TKI, the CCYR rate was 20%. So it's probably correct for Bosutinib. This is a busy slide, which isn't that easy to understand, but basically, if you look on the left, in gray are the proportion of patients who started in the study with the BCR-ABL1 more than 10%, and the green levels going from bright green down to a very pale green show the proportion of patients who would have achieved a much better and deeper response. And on the right, if you look at the histograms, you can see it's moving across with time. Fewer patients are in a poor position, more patients are achieving the deeper responses. The study does require a little bit of scrutiny, because although I think it shows very clearly that Asciminib is a very effective drug, the study has been criticized. It's nobody's fault that the study is subject to a little bit of criticism. Bosutinib was licensed for patients who had failed prior TKIs at a dose of 500 milligrams. So when this study was designed, the FDA insisted that the comparator arm had to be Bosutinib at 500 milligrams daily. Those of us who've used a lot of Bosutinib know that this is a very unpopular dose with patients because it causes quite dramatic gastrointestinal side effects. And basically, the patients have diarrhea for the first 2 weeks on the study, and often they want to stop the drug because of these side effects. And because of this, what happened in this study is that many patients who were randomized to the Bosutinib unfortunately came off the study prematurely because of the side effects. And what you can see from this slide, and I'll go into the detail a little bit more in the next one, is that both drugs cause some level of side effects, probably not very much difference between Bosutinib and Asciminib in terms of all possible adverse events. But you can see from the middle histogram that you were more likely to discontinue Bosutinib because of an adverse event than you were to discontinue Asciminib because of an adverse event. And then this shows very dramatically that both drugs are quite good at causing thrombocytopenia and neutropenia, but Bosutinib is especially good at causing diarrhea, nausea, rash, and vomiting, and of course the side effect that we all worry about a little bit, the drug-induced hepatitis, which Asciminib seems to have a very low incidence of all these side effects. This is one of these box plots that if you look at the 0 to the left, we're looking at side effects that would favor Asciminib, and to the right, side effects that would favor Bosutinib. You can see very clearly that there's not much on the right. But if we're talking about clinically meaningful reduction in side effects, it's really the nausea and diarrhea where Asciminib wins. And if we look at this efficacy and safety summary for this study, Asciminib on the left in green, Bosutinib on the right in blue, you can see that more than 50% of the patients at the time of this analysis were still continuing Asciminib, whereas only 20% still on Bosutinib. The MMR rate, the MR4 rate, MR4.5 rate are all about twice as high with Asciminib as with Bosutinib. Similarly, the complete cytogenetic, whether it be done by cytogenetics or by BCR-ABL less than 1%, twice as good for Asciminib as Bosutinib. So it's a very, very useful drug and seems to be very well tolerated. Let's go to another case now to lighten the amount of data. So this was a young woman who was diagnosed many years ago now, 2007. Again, a very typical presentation, weight loss fatigue, high white count, spleen 4 centimeters below the costal margin. She had no additional chromosomal abnormalities, and again, in retrospect, her ELTS and indeed her SOCOL at the time was low. Started imatinib, 400 milligrams daily, responded exceptionally well. The only drug available to us in first line at that time. Unfortunately, she tolerated it very, very poorly with profound lethargy, joint and bone pain, cramps, and nausea. Because she'd done so well, we tried to reduce the dose, and this did not improve her side effects at all. In 2009, when dasatinib became available as a second-line drug, she was switched to dasatinib. Perhaps in retrospect, we might have started her on a lower dose than 100 milligrams daily. She responded exceptionally well, but she still has exactly the same symptoms, and she deliberately takes drug holidays because she's finding it almost impossible to hold down the job because of the side effects of her drug. So whenever she has a particular deadline at work, she was giving up taking the dasatinib at all. So we tried nilotinib. Again, probably in retrospect, we tried it too high. She maintained her MR4, but still had exactly the same lethargy, joint and muscle pain. We brought down the dose quite quickly. Her symptoms did not improve. In 2016, we switched her to bosutinib. You can see by now we'd learned our lesson with the particular starting dose. So we started her on 200, and she developed, unfortunately, a transaminitis. We were a bit stuck at this point because we did not want to put this young woman on ponatinib because we thought it would be a lifelong drug, even if she could tolerate it. So in 2017, we tried a lower dose of dasatinib again. And although she had been better from the point of view of fatigue, myalgia, and arthralgia on the bosutinib, they all returned on the dasatinib. So we gave up and we did try ponatinib. The lethargy and joint pain continue. She's still maintaining a very, very good response. So we stopped the TKIs and tried pegylated interferon in the hope that this would be a drug that she would tolerate rather better and it would maintain her molecular response. So here is a timeline of the various drugs that we tried. You can see that the myalgia, arthralgia, and fatigue were features of everything except the bosutinib, and indeed they were features of pegylated interferon. Now, I don't know about you, but I guess some of us have patients like this who, by the time you get to their 7th drug, you begin to wonder whether these side effects are really anything to do with the drug or are related to another comorbidity, or indeed related to the fact that maybe the patient just doesn't want CML, doesn't want to be on a drug, and finds it all a bit overwhelming. So we were beginning to consider whether we would ever worry, whether we would ever find a drug, and whether we would just have to go with the smallest dose of something that made her able to hold down a job and have some sort of social life. But in 2019, like our previous patient, we got access to Asciminib on an expanded access scheme. We switched her to 40 milligrams a day, and within 2 weeks, she felt wonderful, which made us all feel really bad about being suspicious about her side effects. She was able to exercise, she was cooking and entertaining friends to dinner, she was working full time, normal quality of life. And remember, she'd been on the pegylated interferon, so she'd lost the best response she had, but she's in major molecular remission. So this is a schematic of a PCR over the time. You can see it going up and down, but in general being very responsive, at least in major molecular remission for most of the time, and some of the time in MR4. And here she is on Asciminib over time. She's now down to near MR 4.5 or 5. And the story gets even better because this young woman is now in her 30s and desperately wanted a child. So we referred her for in vitro fertilization because we didn't want her off her drug for very long. She had a positive pregnancy test after the first implantation. She'd stopped the drug at the time of the embryo implantation. She delivered a normal, healthy daughter some 9 months later. She stayed off the Asciminib and indeed has been in treatment-free remission ever since. So a wonderful outcome for this young woman. So we've had 2 patients who've done really, really well on Asciminib. Let's look at another patient. This man was 74 when he was diagnosed with CML in chronic phase in 2015. He had a number of comorbidities at the time of transplant. He had an acute kidney injury. He'd already had a deep vein thrombosis, and he had presumably ischemic heart disease with first-degree heart block. This would tend to put us off quite a lot of drugs, but he also had Crohn's disease as a past medical history, had undergone subtotal colectomy and had an ileostomy, and is an ex-smoker. He had a bit of a high white count at diagnosis. You can see 375. So because of his renal impairment and his thrombosis, we treated him with leukapheresis, hydroxycarbamide, hemodialysis, and anticoagulation, got him a bit more stable, and started imatinib. It was poorly tolerated, lots of muscle cramps, problems with the stoma output, and thrombocytopenia. We tried low-dose nilotinib later that year. He got an okay response. He was in complete cytogenetic remission at 12 months, but still troubled with thrombocytopenia. And unfortunately, about 9 months later, developed crescendo angina, which is not uncommon, of course, on nilotinib, which necessitated its cessation. We moved on to dasatinib, which unfortunately caused grade 3 thrombocytopenia. We tried incredibly low dose bosutinib, 100 milligrams daily, slowly increasing, but he developed a really troublesome anemia requiring erythropoietin. And unfortunately, which is occasionally what happens with bosutinib, his renal function became worse. In October 2018, he started low-dose Asciminib of 40 milligrams daily. It was incredibly well tolerated. His anemia resolved. He was off the EPO. His renal function essentially went back to a much better position. He responded very well with a major molecular remission 15 months after starting the Asciminib. Unfortunately, later in 2020, at the age now of some almost 80, he succumbed to COVID-19. So that's a very sad end, but obviously a very good drug in a patient who's elderly with a lot of comorbidities. So it does offer you the option in those situations. And this is his case history over the timeline. And you can see that cytopenia had been a big problem till he hit Asciminib. And you can see what happened to his platelet count. Big problem with it on all the drugs until it returns to normal on Asciminib. And here is his RQ-PCR, was rarely in anything approaching major molecular remission until he started the Asciminib. Now, I'm moving on just towards the end of the talk. You'll be pleased I'm coming to the end, I think. Just very briefly to give you an update of what else was presented at the ASH meeting. So I pointed out to you that the original studies of Asciminib also included 3 studies looking at the combination of Asciminib with imatinib, dasatinib, and nilotinib. And remember that because Asciminib works in a different way with the myristyl inhibitor, there was hope at the start that actually the patients who were really refractory you could use Asciminib in combination with a standard ATP binding competitor, one of the other TKIs. Now, there's not so many patients enrolled in all these studies. We're looking at numbers in their 20s. You can see that about half of them were able to continue on the combination, but there were quite a lot of discontinuations or adverse events. And we had some patients in these studies, and they did find it difficult to tolerate the combination. So if you look at the instance of grade 3 or greater adverse events, are really quite high at over 70% in all of the combinations. Between 10 and 20% had adverse events leading to discontinuation. And if you look at the adverse events leading to dose adjustment or interruption or requiring additional therapy, things like GCSF or whatever, it's really very high with these combinations. The arterial occlusive events, there were some. You can see about 10%. I mean, it's very small numbers, so it's difficult to use percentages, but you can see that there are arterial occlusive events, particularly in the Asciminib plus nilotinib. The combinations were very good at achieving major molecular responses, and those major molecular responses tended to increase with time. I'm struggling a little bit because my little picture is over just bear with me while I try and move that. Don't seem to be able to remove it, but I think it's interesting that the combination with imatinib was not as good as perhaps we were hoping at the beginning. So I'm not sure how much future there is in the combinations, and I think it's early days still, but I just thought I would share that with you. Now, I've given you a very positive outlook on Asciminib, but I think it's only fair to finish with a case history where it didn't go quite as well. So this is a 61-year-old arteriopath who was diagnosed in 2017. He's a long-term smoker. He's a heavy drinker. He doesn't as yet have diabetes, but has a very strong family history of diabetes. For understandable reasons, he was started on imatinib, but did not respond. He was switched to dasatinib, got a CCYR at 3 months, which is 10 months after he commenced treatment, which is very good. But he developed a very profound depression, which is not a side effect that I really associate with any of the TKIs. I mean, we saw it with interferon, but I have not seen it particularly with these, and particularly not with dasatinib. So his depression was treated, and he was convinced it was related to the dasatinib, and the dasatinib was discontinued. And indeed, his depression improved, perhaps because of the antidepressants, but his RT-PCR increased. So we started him back on the dasatinib, and his depression returned, the dasatinib was discontinued, and again, he improved. And at this point, I mean, he's quite a genuine guy, so we began to think this was something real. So we switched him to bosutinib. The depression was better. He responded, but unfortunately developed the transaminitis. Switched him to nilotinib, responded well, no depression, no transaminitis. Unfortunately, just over 2 years ago, he developed very severe peripheral arterial occlusive disease requiring stenting. So clearly he couldn't have nilotinib, he couldn't have ponatinib. So we stopped treatment with the TKI. We put him on hydroxycarbamide, but never really gained good hematological control. He lost his responses very quickly. He was never a candidate for treatment-free remission. His
I think she'll log in again. She logged out. Waiting. Hello?
Hi, when did you lose me?
Uh, it was about 7-8 minutes ago.
Oh, right. So I'd come to the end. So not so bad.
Towards the end.
I'm sorry about that.
No,
The
no.
problem is you can't tell. I mean, there's no way to tell.
Yeah.
And only at the end, when I was expecting things to start, I went to my email. Sorry about that.
No, that's okay. Should we go to the question answer session straight away, or you have something left to present?
No. It's fine. Let's go to the question now.
Okay, fine. So, friends, all of you, whoever wants to ask any questions, if you want to open your videos, and please use the raise hand sign. We start with the questions. Yeah, Dr. Narendra, go ahead.
Hi, it was very nice talk, and we have now another drug which acts differently than the other TKIs. So it may have the advantage of combination therapy also. So my question is whether any trial or any after that FDA approval, any trial is there in pediatric age group also? And another question is whether do you have any experience of stopping it and then the effectivity is maintained despite stopping because of any reason if people stop it using further, maybe because of side effects or financial reason, whatever it is. So these two questions.
I am not a pediatrician, so I am not completely familiar with Novartis's plans for the pediatric population. I would hope that they are considering a study in a pediatric population, but I suspect the Novartis people will be able to tell you that better than I would. If you remember the second case, she was able to stop the Asciminib for her pregnancy, and she remains off the Asciminib as of today, so about a year after she's delivered, about 18 months after she delivered the baby. But she was a patient who had had very deep responses for a very long time. Now, when she came off the TKIs and she went on to pegylated interferon, she lost MR4, but maintained her major molecular remission. And she got a deep response with the Asciminib, and she has maintained a very deep response off it. So she's just one patient who it was a very good patient, perhaps anyway, for trials of discontinuation. I think it's a bit early to be talking about stopping Asciminib, because by and large, we're using Asciminib for patients who have failed many, many other drugs. So they're not exactly a great choice for a stopping study. Stopping will be built in eventually to all the first line studies, so we'll see, but it'll be a few years before we get that.
Yeah, thank you.
Thank you, Dr. Narendra. A question from the audience. How do you choose between Asciminib and Ponatinib in a given patient?
So I think they're both great drugs in terms of efficacy. I mean, Ponatinib is an amazing drug in terms of efficacy. If you look back to the very quickly aborted phase 3 study in newly diagnosed patients, even though very few patients, they stopped the study because of the worry about arterial occlusive events, but the few patients who got to 12 months on Ponatinib were in very deep molecular responses compared to virtually none on Imatinib. So it's efficacy-wise, it's a great drug. Asciminib, I think, I don't know whether it's as effective, but it's pretty much almost as effective. The only way you can, because they haven't gone head to head, of course, the only way you can estimate that is whether the rates of CCYR and MMR are pretty equivalent in the Asciminib as third line compared to Ponatinib as third line, and they look like they are. The T315I issue is not completely resolved with Asciminib. So I think if the patient has a T315I, I would use ponatinib. Obviously, your individualized treatment is a little bit dependent on the presence of comorbidities and the age, etc., etc. But in general, for T315I, I would start with 45 milligrams of ponatinib, and I would cut back to the 15 as soon as I got an indication of a complete cytogenetic response or a PCR less than 1%. Because actually, over the course of the first year, the average dose of ponatinib in these patients is really quite low because you can cut back so easily. So definitely for T315I, I think there's an argument for ponatinib in patients with other kinase domain mutations, because certainly in the UK experience, they don't do so well with Asciminib. And of course, if you're looking at a young patient who has no comorbidities and might be able to tolerate ponatinib, it's a moot point, really. I think maybe for resistance, I would use ponatinib. For intolerance, I would use Asciminib.
Thank you. Dr. Urmimala, your question.
It was an excellent talk. My question is, where do you place the role of hematopoietic stem cell transplant now for patients who are resistant to more than 2 lines of TKI with the advent of Asciminib?
Well, it's a good question, and I hope you caught that last case history where we did have to go to transplant with that patient. My feeling is that any patient who is resistant to a second-generation drug, truly resistant to a second-generation drug, irrespective of whether it is given first or second line, should be considered for transplant, in as much as you should start looking for a donor. Because actually, patients who are resistant to second-generation drugs are in big trouble. If they have a mutation that tells you what drug to use, you're probably going to be okay. So if they have a V299L or an F359B, you will find a drug for them. If they have one of the mutations that can really be quite troublesome, like an E255 or Y253, where there isn't an obvious choice of another second-generation drug, and if they don't have a mutation at all, you have to start thinking about transplant at that point. Now, it's going to take you a while to find a donor, so you're obviously going to give them another drug, and that drug is going to be ponatinib or Asciminib, and you're going to monitor the PCR. So if their PCR falls, you feel pretty comfortable, and you can leave them on that third generation drug. If the PCR doesn't fall, you should be moving them off to transplant. I don't know how much mileage there is in a resistant patient for Asciminib after ponatinib or ponatinib after Asciminib. I think if the patient's resistant to ponatinib or Asciminib, they should go to transplant.
Thank you. One more question from the audience. Are there any contraindications for using Asciminib?
Apart from the cost?
Okay.
No, I think the cost is a big one, particularly in countries where, like the UK, where we have a national health service and they don't like high-cost drugs. No, I don't think so. I think it's certainly for the older multiply resistant patient, it's the treatment of choice well over ponatinib, because you wouldn't really want to give ponatinib to an older patient or a patient with ischemic heart disease or hypertension. So no, I think it's a good drug.
Thank you. Dr. Saikat, your question.
Thank you, Dr. Jain, for the excellent presentation and portfolio of excellent cases. My question would be about your experience in post-transplant use of Asciminib in CML patient. Can you use it now?
Yeah, we one of my colleagues, Dr. Fernando, published a letter about this late last year. We've treated a very small number of patients with Asciminib post-transplant for a variety of reasons. As you can imagine, most people come to transplant having failed all the drugs, or they come to transplant because they developed disease progression, they were put back in second chronic phase, and then they went into transplant, and you feel that you want to continue the drug. So if you're asking me, can it be used? Yes, of course it can be used. Is it reasonably well tolerated? Yes, it's reasonably well tolerated. Will it put patients who have relapsed in chronic phase or a molecular recurrence back into remission? Yes. Will it do anything for the patient who's relapsing after a transplant for disease progression? I don't think so. Did you have a patient in mind when you asked the question?
So we have patients who are resistant to imatinib and dasatinib and nilotinib. So in our country, ponatinib is not available. So we get it's imported and give a few months of ponatinib, then do the transplant. And after transplant, sometimes patients BCRA will start rising. And at that condition, we think of adding a TKI. Like I think in this situation, asciminib may be of help. I don't know the side effect profile when we use in a post-transplant patient this drug.
Yeah. So, I mean, relapse in a post. I mean, it's another talk, isn't it? Relapse in a post-transplant patient. So, if they have been resistant to every TKI, including ponatinib, I'm not sure how much asciminib will do to them if they relapse post-transplant. If they've come to transplant for multiple intolerances, then maybe it's a good drug post-transplant. But the reason you're giving a TKI rather than using donor lymphocytes, I think you have to question that, because donor lymphocytes are still highly effective in restoring remission. If the patient's PCR is rising in the first year, you probably wouldn't want to do that because the risk of graft-versus-host disease is very high. But if it's rising beyond the first year and your resources are quite limited, I would be inclined to go after donor lymphocytes rather than give them a TKI. I mean, I'm happy to, on individual patients, if you want to write to me, I'm happy to try and give some advice. But just going after a very expensive drug when lymphocytes could be highly effective, I don't know if that's terribly sensible.
Thank you, ma'am. My second question would be like your experience on pH positive ALL use of asciminib in those situations.
We have virtually none because we weren't part of the study. It's looking very promising. I mean, I have some slides from Dr. Jabor from MD Anderson, and obviously the combination of a TKI with standard ALL therapy has changed Philadelphia positive ALL from a almost uniformly fatal disease to a disease that actually can be managed in many situations. I think there is a move to try asciminib as a monotherapy, perhaps for older patients, and it'd be very interesting to see those results.
Thank you.
Thank you. One more question from the audience. Do you see asciminib moving as the first line of therapy?
Yeah, I mean, that's probably what you missed when you lost me from the talk, because I gave the 4 or 5 slides that came from the Adelaide group of the Ascend study. So although asciminib is currently in randomized studies in first line across the world against imatinib and against nilotinib, Tim Hughes's group, now led by David Jung, were able to do a single-arm study in 100 patients, newly diagnosed, giving them Asciminib 40 milligrams twice a day. And you probably missed the slide, but it was a very carefully thought out study. I don't know whether anybody remembers the tidal study, but this was designed to be treatment directed by PCR response. So patients were followed very carefully in the first year, at 3 months, 6 months, and 12 months. And if at any of those time points they were failing Asciminib, the physician was allowed to add one of imatinib, nilotinib, or dasatinib, or indeed increase the Asciminib to 80 milligrams daily. So they've got very good results. They were presented at ASH in 2022 and again in 2023. In 2022, it looked like Asciminib was a miracle. In 2023, they've got, of the 100, they've got one patient that went straight to lymphoid blast crisis very early on. And they've got 16 patients who've had to discontinue, of which I think about 6 discontinued for lack of response, lack of early molecular response, or loss of response. And they have seen a couple of those myristal pocket mutations. So it looks very promising. It's not perfect.
Thank you. Dr. Girish, your question.
Are you on mute?
Yeah, so we'll take one question from the audience. You have 10% of patients who have primary resistance to TKI. So is there a role for upfront mutation studies?
No, I don't think so. It's really a situation, I think, still for academic research studies to collect information. Most of the patients who are primarily resistant don't have a kinase domain mutation at the time of their resistance. The time that you find more easily kinase domain mutations are in people with secondary resistance. So they respond and then they lose their response, and then you find the mutation. And if you think about it, that's completely logical. Because if the mutation is present at diagnosis, it will be in the mixture of a massive number of cells and lots of different clones of cells. You're very unlikely to find it, even with next generation sequencing. But the moment you apply the pressure of a standard tyrosine kinase inhibitor, that resistant clone will grow. And that's why you find it in secondary resistance. In primary resistance, it's very unusual to find it. And I don't think we're going to find them before you start any treatment, before you start applying any selective pressure. Probably there's more mileage in looking to see whether somatic mutations in genes other than BCR-ABL, or whether there's a gene expression signature that indicates a patient is likely to run into trouble. They're probably the way to go, rather than doing NGS on every newly diagnosed patient.
Thank you. Dr. Fahima, your question.
Yeah. Dr. Jain, it was a fantastic lecture, and making us go through the real-time events, what happened in your patients, was fantastic to listen to. This is something we experience in our clinical practice as well. So my question is somewhat related to what Dr. Saikat was asking. We had a very young CML, 22-year-old male with ulcerative colitis, and who never achieved MMR on second-generation TKI. As you know, we don't have access to ponatinib. So he was on dasatinib, and dasatinib was actually worsening his ulcerative colitis. The best response he had with PCR was 3% BCR-ABL, and he had a 10/10 donor. So we went ahead with an allogenic transplant. Now my issue is, like, he's post-transplant. I don't know which TKI to put him, and right now he has some evidence of GVHD. Despite that, even at 6 months post-transplant, his BCR-ABL still is in the range of 2 to 3%. So how do we go about this? You think Asciminib will play a role here?
It could do. So did he never had a mutation?
We could never identify a mutation, ma'am. No.
Okay. Well, he has some GVHD, so presumably you've got it, still got him on immunosuppression.
Yeah. Hello.
Yeah, you're immunosuppressing him still. What are you using?
We have actually tapered the dose of cyclosporin, ma'am, because we wanted the BCR ABL to fall, because at 3 months also, it was around 2.5%. So we actually tapered the GVHD prophylaxis because it was a very tolerable GVHD. It was just skin and eye, which was symptomatically managed.
Yeah. And what's happened to his PCR? Because they do go down once you remove the.
It is the same. It's the same as pre-transplant. 2.6 to 2.5, 2.4. And at 6 months as well, it hasn't fallen from 2.3%, which he had at 3 months post-transplant.
Yeah. Then if you can get your hands on Asciminib for a post-transplant patient, I mean, it's obviously not its licensed indication, then it's probably worth trying, because what you really want to do is to try and drop his PCR until you get him beyond the first year, and hopefully without any residual GVHD, because then you can try some more lymphocytes. Can you routinely do chimerism?
We can, yes. We do the chimerism at 1 year and day 100. Day 100, he was 100% donor.
In T cells or in blood or both?
In blood and both.
He can't really be if he's still got a positive PCR, though, can he? He might be 100% in his T cells, but he's got to have some of his original disease.
Okay.
So it's probably worth repeating that now.
Okay, ma'am. We are about to. He is due
Yeah.
for his next chimerism study right now.
Yeah. If you can get Asciminib, yeah, by all means, have a go.
Okay,
I mean,
what
even low, and you can't get Ponatinib, can you? Because 15
we
milligrams.
can't. It's very difficult to and it's
Yeah.
very expensive. Even if we import, it's very expensive for us.
Wouldn't Asciminib be very expensive too, or could you get that?
We were actually having patient assistance program till now via Novartis. So we were able to give most of our patients, but this patient wouldn't fit into that category for us to avail free Asciminib. So we are just waiting for the launch, and maybe free. We don't know the cost as of now for Asciminib. I don't know.
I mean, I don't know if there's anybody from Novartis on there listening to this, because I know they were thanked at the beginning, but it's probably worth approaching them to see if they'd give you some, just to see whether you can drop the PCR.
Thank you. Yeah.
Thank you, Dr. Fahima. Dr. Girish, are you there now?
Yeah, thank you. Thanks a lot, Dr. Rapperly. This is a really nice talk. And we had one patient with Asciminib with the Novartis assistance program with as a compassionate basis for T351 mutation patient. My kind of like thinking, like you gave a small, I mean, because in between the video that went off, this combination of TKIs, like, especially in India, the getting newer TKI is very difficult and very expensive. So whatever we got, we have to use it. I mean, we could see like not many combination TKI studies are not there, and why this one was done, and whether there is a combination of TKI with the interferon, good old drug, will kind of help in resistant cases. I mean, some thought. I mean, so
I apologize, but I'm not entirely sure I understand the question. Do you mean Asciminib in combination with another TKI?
No, any other two TKIs in resistant cases. I mean, I know it's theoretically should not be, but why it was done with Asciminib and other TKI, the combination. First thing.
Well,
second thing.
The problem is that there are overlapping toxicities, particularly hematological toxicities. So it's very difficult to get two drugs in. Yeah. And even the Asciminib combination studies, we've had patients in those combination studies, and you almost inevitably end up reducing one or other of the drugs.
Okay.
And then you wonder whether you're doing any good at all, because maybe you're not giving the right dose of the right drug. I think it's going to be difficult.
Difficult.
Now, interferon, we have many years ago, we published a case report where we gave somebody, we added interferon to their TKI and got a deeper response. And we do it from time to time. It has, sometimes it looks like it's working. Most of the time it isn't. But if you're really stuck with the patient and you've exhausted all your TKIs, then adding a bit of interferon might be worth having a go for, because your alternative in that patient is to send them for transplant, and they may not be eligible for transplant, right?
Exactly, such situation.
Yeah.
Okay, thank you.
Thank you. Again, a question from the audience. Your comments about trying TFR on second-line treatment with TKI when patient had resistance to the first line.
Well, we've also recently published on this.
Not audible. Yeah, you'll have to look forward.
Oh, sorry. We've also recently published on this. It's definitely possible. It's definitely possible. It's particularly possible in the situation where the resistance was due to a kinase domain mutation for which you have a good treatment. So we have definitely discontinued in patients who responded to the correct drug in second line. We also have patients who were resistant to usually imatinib, who don't have a kinase domain mutation, but who responded extremely well to their second line drug. We've also discontinued them. Remember, we've been using these drugs for a very long time. So we're talking about eventually being brave enough to discontinue the second line therapy when maybe the patient has been on it for 10 years. So we know we've really established a very deep response. And I think it's possible. I mean, and because the patient almost inevitably gets their response back if you need to restart, then it's worth a go. It's worth a go. It's going to be, you're going to have less success for somebody who's demonstrated resistance than you will have for somebody who's been intolerant, but there will be successes.
Thank you. Last question in the chat box is, somebody becomes pregnant on TKI. Do you just stop TKI or you terminate the pregnancy?
We stop the TKI.
And continue with the pregnancy. Right.
I mean, it's a generalization. I mean, obviously it might depend on the phase of disease. I mean, if they were in blast crisis, I would probably terminate the pregnancy. If they're in chronic phase, I would just stop the TKI.
Amit, your question. Thank you.
Thank you, ma'am, for that fantastic talk. I have a case to discuss with you. There is a 45-year-old gentleman who presented me with a CML chronic phase, but on imatinib he loses the response, switched over to dasatinib, but on dasatinib 50 milligram, he becomes profoundly cytopenic. So I switched, because of cytopenia, I switched to nilotinib. Even with nilotinib 300 milligram twice a day, there is profound cytopenia. Bone marrow biopsy is totally hypoplastic marrow. RT-PCR is for BCR-ABL is rising. So what would you do next, ma'am? Can we go for Asciminib-based therapy here?
So what happened to the PC? What was the PCR before you started the nilotinib? Was he in a good response?
It was 0.1, and now it is 3%.
And you started 300 milligrams BD.
300 milligrams BD. Profoundly cytopenic.
And you think he's compliant?
He is compliant, yes.
Even with the twice daily dose?
Yes, ma'am.
Look for a bone marrow transplant donor. Look for a stem cell donor. And if you can get Asciminib, try it.
Asciminib will not work? Asciminib?
Yes. I would start the Asciminib at 40 milligrams daily because he's been thrombocytopenic with all of them, cytopenic with all of them, yeah?
Yes, yes, ma'am.
Yeah, so start the Asciminib gently because
So
it
40
also
milligrams
causes cytopenia. So
twice
start
a daily
with
will
40.
be a good, no problem, right, ma'am?
Yeah. Hmm?
40 milligram twice a day is okay?
No,
Once a
start it gently, 40 milligrams once a day.
Okay.
Otherwise, you'll get more cytopenia and you'll have to stop.
Sure, sure. Thank you, ma'am.
One more question from the audience. Those patients who have dasatinib-induced pleural effusion, does Asciminib lead to recurrence of pleural effusion?
We've not seen it yet, but we used to say that about bosutinib.
That's the last question in the chat box. Any question from the people here? Yes, Dr. Hunt from Myanmar. Hi.
Madam, thank you for the comprehensive talk. May I know your line of management of CML through secondary fibrosis with severe cytopenia with high PCR AVL?
I missed the very beginning of the question.
CML with
So-
fibrosis, having cytopenia and high BCR level.
And that was a diagnosis or a year in or?
So analyze CML and bone marrow reject shows fibrosis.
Is this
But
an
is this-
initial diagnosis?
Analyze CML no case or CLL for years, 2 to 3 years. Right?
After 2-3 years. Okay.
And which TKI have you used?
So imatinib to dasatinib.
They have a mutation?
Actually, patients not can afford for kinase mutation.
Not tested.
Sorry, they haven't looked
Yes.
or? I think it's difficult. I think it's been shown on many occasions that patients who really struggle with cytopenia
Yes.
have a very poor prognosis. And once they have failed a second generation drug, you ought to be thinking about transplant.
Yes.
If the patient is not eligible for transplant, they don't have a donor or they're too old or they have lots of comorbidities, then you can try something like Asciminib, but the chances are you will also get a cytopenia. It's a poor prognostic feature and the myelofibrosis doesn't help. They haven't got a JAK2 as well. They haven't got two diseases, have they?
No, man.
But myelofibrosis in a patient with CML is a very poor prognostic feature. So if you can get the patient to transplant, that's where I would go.
Yes. In the case of severe cytopenia, or where you give TKI, madam, if cytopenia is due to disease burden,
In CML, the disease burden doesn't normally cause cytopenia, right?
yes.
I mean, the patient must have had a high count at diagnosis.
If neutrophil less than 1 and platelet count is less than 10, where you give TKI or Asciminib,
Platelet count less than 10.
yes.
The patient needs a transplant.
Yes. Before transplant, madam, how will you?
Well, the only way you can give somebody a drug that causes thrombocytopenia if their platelet count is less than 10 is to give them platelets every day,
Yes.
right? Can you do that? Because otherwise they're going to bleed.
Yes. If high cytopenia is due to disease burden and high PCR AVL, how should we proceed?
But I don't know why you keep telling me that the cytopenia is due to the disease burden. You're talking about somebody whose disease is progressing, right? Talking about somebody going into
Yes.
blasphemous. Yeah?
No, but PCR AVL.
It doesn't matter what their BCR-ABL is. They're not responding to imatinib and dasatinib. They've developed fibrosis and they're very cytopenic. It means the disease is progressing.
Yes.
Yes, disease is progressing. Can you get you could give AML-like therapy?
No, plus crisis managed via cytopenia and bone marrow is hypocellular.
Yeah, but it's a fibrotic progression. That's
Yes.
that's a feature of progression, developing myelofibrosis.
No
Did they
high
have
plus
myelofibrosis at diagnosis?
yes, secondary fibrosis. Yes, there is
It's a
some
feature
of
of
fibrosis.
I can't say it enough. It's a feature of disease progression. Your patient is no longer in chronic phase.
Yes.
Okay?
Yes.
Thank you.
So AML actually meant to transplant. So you mean that?
Right, so.
Yes. Thank
Okay.
you.
Thank you. Any other questions? Okay, if none, then Dr. Jain, thank you very much for sparing your morning, being with us, updating us on Asciminib. Asciminib is going to be available to us very soon, within a week or two. And therefore, this webinar was very timely. We have used it at the moment as a patient assistant program only. So just few patients experience with everybody. But now it's going to be officially available with help and Indianized price. So maybe we can afford that. So
I hope.
this will be helpful to us.
Hopefully you'll be making your own soon.
Thank you. Thank you.
Okay, thank you very much. Thank you.
Bye. Bye-bye.
Bye.